Hi, welcome to Iron's Health Talk with Dr. Akram, and I'm Akram. In this program, we'll be talking about all kinds of different health issues with different experts in the field. Today, we will be talking about ischemic heart disease and coronary artery bypass grafting. So sit back, relax, and enjoy your time with us. Despite increasing survival, cardiovascular disease remains the primary cause of death worldwide, with an estimated 7.4 million annual deaths. The main symptoms of ischemic heart disease is chest pain, angina pectoris, most often caused by blockage of a coronary artery. The aim of coronary artery bypass surgery is revascularization achieved by surgically grafting harvested arteries or veins distal to the coronary lesion, restoring blood flow to the heart muscle. Ischemic heart disease was first described in the 18th century by Giovanni Batti Morgagni and Frederick Hoffman, who identified anginal syndromes and reduced coronary blood flow, respectively. It is estimated that 60% of the world's cardiovascular disease burden will occur in the South Asian subcontinent, despite only accounting for 20% of the world population. This may be secondary to a combination of genetic predisposition and environmental factors. Organizations such as the Indian Heart Association are working with the World Heart Federation to raise awareness about this issue. First of all, let's look at what is ischemic heart disease, its symptoms, signs, how does it affect our lives, and what kind of remedies we got in store. Let's welcome our special guests. Three of them joining today. Dr. Shakil Farid, joining from Oxford. He's a consultant cardiac surgeon in Oxford, and he is a director of FRCS cardiothoracic courses. And also Dr. Vivek Srivastava, also joining from Oxford. He also works as a consultant cardiac surgeon at Oxford University Hospitals. And Dr. Chauduri, our son from USA. He is a clinical professor of medicine in University of Nevada, Las Vegas, School of Medicine. And he is also director of cardiac catheterization laboratories, University Medical Center. Hello, welcome to our program.
Hello, thanks for the invitation.
Shakil, how are you doing?
Fine, thank you.
Vivek?
Thank you, yes, thank you for having me here.
And Ahsan?
Yeah.
Hi, how are you?
Oh, very good, very good. Nice to see you. How is USA?
USA is good. We are in Las Vegas. This is actually midday. And greetings from the USA.
Is it warm there in USA? Is Las Vegas, I suppose, it sounds like a nice holiday destination for me.
It is warm, but COVID-19 is in full speed here. We are seeing a surge.
But your patients are in best hands. I know we got the best specialists in our show today. But anyway, and also I want to welcome my special guest, Hargo, who is here in our studio with us. She got so much interest in the program, and she wrote to me about, you want to be in the show?
Yeah.
Can you tell a little bit about you, Hargo?
I'm 15. I was wondering maybe if in the future I would like to do something related to medicine. So I thought it would be quite interesting to actually learn about it.
And you got lots of questions, as I can see. You got lots of papers. That's interesting, Hargo. Thank you very much for joining us. And
you should become a heart surgeon in future. Okay?
There we go.
Good female heart surgeons in the world.
That's a good idea. Here we go. Yeah.
Don't become a cardiologist.
By the way, Shakil, the head of surgery here in my hospital is Dr. Queen Ficus. She's a female surgeon.
She's a female
There you go.
surgeon. Oh, excellent. All right. That sounds good. So here we go. We got something to look forward, yeah? Okay. This is a live program. So call us on 0203 515 5788. If you have questions or suggestions, or write to us healthtalk@intv.co.uk. And you can also follow us on Twitter and Facebook, Iron Health Talk with Dr. Akram. And of course, you can watch us on Facebook Live, intv.co.uk. Okay, let's go back. Vivek, how is Oxford?
Oxford is good. I think I have my good colleague here as well, and it's always better when he's around. But no, Oxford is good. Thankfully, we are picking up on what we are able to do just now, so that has been a bit of a problem in the last few days. But hopefully, we are looking to normalizing our activities. So, thank you.
Thanks a lot, guys, joining with us today, and especially Shakil and ahsan. Both of them are on call for the hospital, and they are in the program because we planned it and we couldn't change it. And I'm really grateful for you, both of you, being with us. And hopefully, nobody is going to call you during the program, so we can conduct the program. Anyway, that'll be great. Okay, let's go back.
I can ask my good colleague, Mr. Vivek Srivastava, to cover me.
Sorry, I'm on the program. you are by yourself, sir.
Okay, let's go back. Ahsan, can you say a little bit about ischemic heart disease? What is this about?
So when you talk about the, I would rather say coronary artery disease, the one that we see the majority of the deaths are due to, is actually the formation of the plaque buildup in the coronary artery that supplies the heart muscle. So these plaques can compromise the flow, and that can lead to symptoms like chest pain on exertion. So demand supply mismatch. In many patients, it can be just plaques sitting there is no flow compromise, and there is no symptom. So it can be asymptomatic, and it can be symptoms with exertion because of the plaque buildup and flow compromise with demand supply. But uniquely, as we all know, there is another problem with the plaque, that these plaques can rupture or can get erosion and can activate the clotting system and the platelet activation and present as what we call acute coronary syndrome, meaning heart attack in different forms.
Okay.
So,
what we're talking about here is the blood vessel which is supplying to the heart muscles itself, isn't it?
correct.
Exactly. I just want to make it clear for our audience. So these are the special vessels which supply blood to the heart muscle. Hanko, you said you read a little bit about that.
Yeah.
Can you tell a little bit about it? Okay, from your perspective.
Well, I read a bit about the vessels,
Yeah.
and it's like when there's build-up, the blood might not be able to reach the heart properly, so it might not be able to function and could lead to a heart attack.
So it can lead to heart attacks. That's what we're going for. Is that right?
Yes, but it is important to realize that the presentation can be in a stable condition. That means the patient has some chest pain, and there are some atypical symptoms. Particularly, we see that in the females, fatigue, shortness of breath, and these are like stable over time. But it can also present as sudden onset of chest pain, short of breath because of the plaque instability.
So you're telling somebody who's... Yeah.
At the same time, we want to warn the patients and population, particularly in South Asians, that many plaques can be asymptomatic. Those who have risk factors, and this is the preventive side, if we think about the pathophysiology of the coronary disease, many can be asymptomatic with plaques. But if I have risk factors, I need to be careful about the risk minimization so that I don't end up with plaque buildup and angina, or for that matter, end up in heart attack.
So what you're telling is somebody who is normal, who's leading a normal life, suddenly get chest pain, and suddenly you realize that his heart has been, these vessels been blocked for a while. Is that right?
Correct.
Okay. And Shakil, how common you see patients being referred to you for heart surgery or for this kind of surgery?
Yeah, so specifically related to ischemic heart disease, we do see quite frequently patients being referred for surgery. Now, if you think about all the patients who undergo angiogram, around 30 to 40% of them end up needing some form of treatment. Of those 30 to 40%, about 80 to 90% undergoes angioplasty, and 10 to 20% comes for surgery. Now, people who have triple vessel disease, especially patients with diabetes or reduced heart function, or patients who have disease in the left main stem, we say, which is like near the origin of the artery, coronary artery, those patients actually usually come for heart surgery. And being a big center, we do see quite a lot of patients, like every week we get referred quite a lot of patients for coronary artery bypass grafting.
So 20% of them being referred with chest pain might end up with some kind of heart surgery. Is that right?
No, so the number is not quite right. So if you have symptoms of heart disease, you end up needing an angiogram. Out of those 100%, around 30 to 40% need some form of treatment, whether it's stenting or surgery. Out of those 40%, around 70 to 80% undergo some form of stenting, only 10 to 20%. So if you look at the whole spectrum, I would say around 4 or 5% patients come for surgery.
Come for surgery.
Yes.
But still there are lots of other procedures we could do before they go to surgery, isn't it?
Yeah, absolutely.
As a first step. Okay. I was just wondering, can one of you explain a little bit about this blood supply to this heart, like in quick format, so we could make our viewers understand what we're talking about?
So,
maybe.
Vivek, do you want to do it?
Yeah, maybe I can do that. That's fine. Sorry, your guest has read up about the heart and conditions and probably read up about blood supply as well. But basically, heart, like any other muscle, is supplied by arteries that supply the pure blood and help the heart muscle function. Now, the arteries are quite small, as you can imagine, so probably about at most 2 millimeters across, and it doesn't take a lot of blockage or obstruction in there to affect how the blood flows through there. So these are arteries that come off the aorta, which is the big artery, the biggest artery coming out from the heart to supply blood to the rest of the body. There are 2 arteries basically, one on the left side, one on the right side. And the left-sided artery is usually the most dominant in most people. So dominant, I mean, it is responsible for supplying most of the heart muscle in about 85% of the people. But it is only a short artery, and then it divides into 2 branches. One for the main pumping chamber, the left-sided heart, as we call it, the left ventricle, and the partition in the heart. And there is one branch that goes to the back of the heart. So the left side is covered by this 2 big branches. And then there is a right-sided artery, which supplies the right side of the heart and the bottom of the heart. But between them, each of them is important because they are all responsible for supplying their own areas of the heart muscle. And if there is a sudden heart attack, then, or if it's a very significant or sudden event, then the other arteries are not able to cover for other arteries, and that results in damage to the heart muscle. But if it's a slow, gradual process, then sometimes we see that little channels develop within the heart muscle that cover for other areas, and people can go on for a long time. And that is why, as Dr. Ahsan explained earlier, symptoms can suddenly appear, but the disease process has obviously gone on for several years, but because the heart has adjusted itself to it, it's kind of not evident immediately. Does that make sense?
Thanks, Vivek. Yeah, that's excellent. We have a caller actually. Let's get the caller as well to join us the program. Hello. 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 Do you hear us? Welcome to Iron's Health Talk with Dr. Akram. I think there must be a problem with call. Okay, let's continue with the program. What are the common symptoms of patients who seek help with you, Vivek?
Yes, that is the interesting thing about the heart condition that we are talking about, ischemic heart disease. And as Dr. Ahsan has already elaborated in quite good detail, there's a whole range of symptoms that people present with. Okay? Classically, what we describe as crushing chest pain or very severe chest pain is probably true only for a small minority of patients, and public need to be aware that that may be one presentation, and that's certainly indicative of really bad heart attack happening or really significant affliction of the blood supply. But more commonly, people may experience just heartburn-like symptoms and are treated for reflux or treated as just heartburn and treated with antacids, but in effect, it may be just a reflection of lack of blood supply to the heart muscle, and people just need to be aware that if it is coming on with effort and it is not going away with just rest and usual antacid treatment, then it is something to be aware of and be actually persistent with your own doctor to kind of investigate it further. That's one way. The other presentation that people can have is, a lot of our, particularly South Asian population, are diabetic, and they may not even experience any symptoms until a proper major heart attack happens. But also, if the heart muscle has been damaged or has been suffering for some time, it may only present as some breathlessness on exertion or more than usual effort. People may notice that they are feeling more breathless and not able to do what they were able to do, let's say, last year. So these are things that people should just be aware of, and because it's such a high incidence of ischemic heart disease, and especially our subgroup of population, it is just something that people should be vigilant for and be actually investigating for it if required. And then, of course, if it's a major heart attack, the pain usually will not subside, and people should seek medical help.
Ahsan, are these conditions reversible? And can ischemic heart disease preventable?
Okay, so let me address your second question first. The clinical impact comes from the plaque burden, as you can imagine. And the more the plaque, the more is the flow compromise, and the more the plaque, there is a potential that the plaque can undergo a process called plaque rupture, plaque erosion, plaque fissuring, and present as what I call this acute ischemic. Ischemia means lack of blood supply. Acute means sudden. Acute ischemic scenario or chronic ischemic scenario. But if it is chronic, you have time to evaluate, right? But in the acute, you need to work very fast to save lives. We don't want to go to the acute situation. And therefore, if someone has the risk factors that we know from, for example, from the Framingham study, that high blood pressure, diabetes, cholesterol high, the obesity, and then all these high cholesterol level, particularly the LDL fraction high, all these contribute. So if we can address this and minimize, these are all modifiable risk factors. We cannot do anything about the non-modifiable risk factors, which is the genetics, which is the family history. But what we can do, and one important thing that I did not mention, is the smoking. Very key that we address this, and then we modify the disease, the risk factors, so that the disease does not come back and take the lives. So that's the preventive side. The interesting question that you asked me, can it be reversed? So plaque, when we see in the artery, and that gives the plaque burden, and the more the plaque, there is the core of the plaque. If it is soft, it becomes vulnerable for plaque rupture and then activation of the clotting system and the platelet activation and full blockage of the artery and then we see the full-blown heart attack. But if you think about a therapy that regresses the plaque, that will be unique, right? We use the statins, and now we know that the statins actually stabilizes the plaque. So if I have plaque, it probably would be stabilized so it would not rupture or would not go through the erosion. So at least I would have less chance of an acute ischemic event. That's one thing. And also, another interesting thing about the reversal, there's actually a study called reversal. Dr. Steve Nissen from Cleveland Clinic was the PI, principal investigator, and they showed that with aggressive statin therapy, if you do the intravascular ultrasound and assess the plaque volume, you actually see there is a regression of the plaque. So we go for the bad cholesterol particle called LDL and lower it down and down, go down below 70, even 50, then we may see some regression of the plaque. And remember, if the plaque volume is decreased even 10%, that will give you a higher lumen area. So even if I don't get a regression, even if I don't get a reversal, at least we can get stabilization of the plaque. So preventive measures are very important. Risk factors are very important. Understanding the pathophysiology is important. And now we are seeing from even the UK studies, if you look at the CT angiograms, we can see the plaque without doing an angiogram, because coronary angiogram, the invasive one, and Shakil and Vivek, you guys know, this is basically luminogram. It gives us the idea about the lumen, but the story of the coronary disease is in the wall of the artery. The CT angiogram is giving us insights about what's in the walls. So good questions, and yes, we can do things that can prevent.
Okay. Shakil boy, can you tell us, is a surgery is the answer, or what else can we do?
So, if you have coronary artery disease, there are three ways of managing the patient. So people who have minimal symptoms, who have single vessel disease, who have non-critical disease, however a little bit of disease, they can perfectly be managed by giving medical treatment, especially elderly patients who do not have much symptoms. It's perfectly all right to treat them with medical therapy. As Dr. Chauduri has said, you can give them aspirins, you can give them statins, you can give them drugs to slow down the heart rate a bit, and their outcome is pretty good. Then the next thing is stenting. Stenting is done in patients who have single or double vessel disease and which are in geographically good position. It's not near the origin of the artery or the main stem of the artery. They're perfectly all right to have stents. And surgery is only reserved for people who have very critical coronary artery disease that is not amenable to stenting, or patients who have diabetes, who have multivessel disease, or people who have very critical disease in critical vessel, which is quite risky to stenting or something. Those patients actually have good outcome with surgery. So we do surgery for two reasons. One is to give survival benefit, another one is to improve the symptoms. So it's really important to realize that there are different ways of treating ischemic heart disease. It's not only surgery. And most of the patients do very well after surgery. We have seen the long-term results, which are fantastic. I mean, in UK alone, if you look at the data, only slightly over 1% patient comes back for a repeat revascularization following coronary artery bypass grafting. If you look at the long-term result, the 5-year survival, the 10-year survival, they are excellent. So, bypass surgery is pretty safe now. It can be done with less than 1% mortality, with very low risk of stroke, wound infection, things like that. So, it's almost like having a routine operation. Our patients come the day of the surgery, they get discharged. Most of the patients get discharged on day 4 or day 5. It's only the really sick patients who need extended stay in the hospital. So yes, I mean, there are different ways of dealing with ischemic heart disease.
Thank you very much, Shakil. We're going to go for a short break, and today we are talking about ischemic heart disease and what we can do for this, especially the surgical management. So far, we have talked a little bit about ischemic heart disease. What is it? What are the symptoms? What we're going to look for? And for the next bit, we're going to look more into the treatment and how to prevent it. So be tuned to Sky Channel 782. Be with us. We'll be back shortly.